Well, good morning. Great to have everybody here. Our forum luncheon did not occur last Monday on our normal time slot because of Veterans Day. And if we could as a group, if you would be so bold and allow us to provide you some gratitude. If you served Americans' armed forces, would you kindly stand and remain standing? Thank each of you. The Salem Chamber recognizes the important impact our veterans have had in not just showcasing the great bravery that each of them have been able to display by stepping forward, but also the foundations that it set for our nation to be able to have election processes, free speech, and many of the things that other countries in this world do not enjoy. So thank you so much to our veterans. It is now my pleasure to introduce our Salem Chamber President, Mike Herron with VIPS Industries.
Thank you. Welcome, everybody. I'm excited to be here and hear about this topic that's impacting our community so greatly and deeply. I'd like to first recognize our forum series presenting sponsor, Hagen Hamilton Insurance Solutions, and today's monthly sponsor, Salem Health and the Salem Health Foundation, who we will hear from later. First, please stand with me for a moment of reflection and prayer, followed by the presentation of our national anthem performed today by Jackie Roche. We take this moment to reflect, each in our own way, on our lives and on this moment. We are thankful for the meal before us, for the hands that prepared it, and for those who serve it. We are grateful for this day, for its blessings, its opportunities, and its challenges. May we lend each other strength and guidance as fellow leaders within the Salem community. May we be deeply driven to always give our best and have the courage to rise and meet the challenges we face. Amen. Jackie.
Oh, say, can you see by the dawn's early light what so proudly we hailed at the twilight's last gleaming, whose broad stripes and bright stars through the perilous fight o'er the ramparts we'd watched were so gallantly streaming, and the rocket's red glare, the bombs bursting in air, gave proof through the night that our flag was still there. Oh, say does that star-spangled banner yet wave o'er the land of the free and the home of the brave?
Thank you, Jackie, for presenting our national anthem. Jackie's the owner and operator of Jackie's Natural Cleaning. If you need a bit more convenience in your life, utilizing products of the utmost quality and friendly to our environment, I encourage you to connect with Jackie. She also serves as a Salem Chamber ambassador, so thank you, Jackie. It's now my honor to introduce our head table today. Dr. Kelly Olson, Director of Clinical Affairs at Millennium Health, Nancy B., Critical Care Director at Salem Health, Chris Gibson, the Executive Director at the Oregon-Idaho High-Intensity Drug Trafficking Area, Beth Black, the Benefits Consultant at Hagen Hamilton Insurance Solutions, and Jim Bauer, Salem Chamber Past President and Chief Development Officer at Salem Health Foundation. Please join me in welcoming our head table. I'd also like to recognize some of our local dignitaries in attendance today. The local elected officials, let me get my list here. We have, I saw our Kaiser City Mayor Kathy Clark, Kaiser City Councilor Sarita Karas, and Marion County District Attorney Paige Clarkson. Thank you. Also in attendance today are our past presidents, Barb Hake-Resch, Jim Bauer, Laura Dorn, Richard Pine, Ryan Albritton, TJ Sullivan, and Alan Rasmussen. And your current Salem Chamber Board members in attendance today, if you could wave your hand so that people know who you are, can recognize you. Alan Rasmussen, Angela Williams, Christy Witzke, Diane McLaren, Jennifer Martin, Katya Mendez, Randy Sutton, Rich Duncan, Roger Hoy, Ryan Dempster, and Ted Ferry. Thank you, guys. And also, I want to give a special warm welcome and thank you for attending to anyone here who's a new member of the Chamber and anyone here who's attending a forum lunch for the first time. We appreciate you investing in us, investing your time in us. So for the second season in a row, our partners at Hagen Hamilton Insurance Solutions serve as our Forum Speaker Series presenting sponsor. If you direct your attention to the screens, we've prepared a short video presentation for you.
So as an employer, we've got young, energetic leadership that is constantly thinking about how do we make things better. They really build out teams and the team environment. Most agencies have got one person who speaks Spanish. We have a team. Most agencies have one person who does Medicare. We have a team. If you want to go fast, go by yourself. You want to go far, go with the team. And so we're able to partner up with the companies that we insure by giving them a team that understands their industry and handle their issues better than most other agencies can.
We're a team. You know, I think that's what makes us so effective. I mean, you're not just getting an agent, you're getting an agency force.
The Hagen Hamilton team, it's family. That's the main thing I love about it. We are all a tight-knit group.
My favorite part about working at Hagen Hamilton is I'm allowed a really unique opportunity to not only be a mom of 4 awesome kiddos, but also support the ag industry, which is an industry I'm really passionate about, was raised in. I'm able to support the people that have supported me.
We look at how we reward our employees. There is definitely innovation that's worked into it. Our health plan is something that's different and unique and something that we've taken out to other employers to help them save money and give better benefits to their employees. It's the same strategy that we utilize. Company-wide, we've got over 70 employees, so you've got to be thinking about how do we attract and retain good people. We've hired, since I've started in May of 21, we have hired over 105 people, and you don't get to hire that many people without having A, an attractive place to work, and then B, an attractive compensation package. Year in and year out, we are ranked as one of the best employers in Oregon, and we're going for our 16th straight this year. And we've been recognized by Oregon State as one of the best family-run businesses in the state of Oregon. So Oregon State University is recognized as, Portland Business Journal has also recognized us as one of the biggest insurance agencies in the state of Oregon. As a company, we are focused on Salem. You know, there's a lot of agents in our industry that are looking at retirement, and you know, they're looking at getting out of Salem, and we're looking at how do we get further entrenched in Salem, and we are going to be an agent in Salem for a long time that people can rely on.
Great. Thank you again to the John family for your continued support. Yes. We're also joined by a number of Hagen Hamilton local team today as well. So it's with my honor to introduce our monthly sponsor today, Salem Health and the Salem Health Foundation. Salem Health facilities include Salem Hospital, West Valley Hospital in Dallas, and the Salem Health Clinics spread throughout the Mid-Willamette Valley. Salem Health serves patients across Marion, Polk, Benton, Lincoln, and Yamhill counties. Their physicians, nursing professionals, and technical team members are recognized as the best in our region and bring top-ranked services to residents across the Willamette Valley. Their values resonate with those they serve: excellence, accountability, integrity, caring, and teamwork. To share more about Salem Health and to introduce our expert speakers, we are very pleased to welcome Jim Bauer to the podium.
Okay, I got to adjust the mic. Am I right? All right. Welcome, everyone, and thank you for introducing us. And really, just amazing to see so many people here. This is an important topic, but it's always just heartening to see the tables filled all the way to the back and having people here who are interested in something that's important to the Mid-Willamette Valley. On behalf of Salem Health and the Salem Health Foundations, we're delighted to be here. This is what we call Community Health Impact Event. And in our way, this is a way to get out into the community and share information about important regional healthcare topics. The thing that I want to make sure I say to you about Salem Health today is that this is community health. It is started by you, by people like you. Over 100 years ago, over 125 years ago, a group of people in this community said, we need more health care. We need real health care. And through this entire period, over 125 years, people like you have been a part of the board, who have been part of the decision makers to build a better and a high quality healthcare system for the Mid-Willamette Valley. What Salem Health does, how they do it, and for who they do it is all in the room. You're here. It's all about you. Dallas Hospital, 107 years ago, same kind of thing. They wanted health care. I can't remember if the name was Dallas Hospital at that time, but the point was they needed local health care. And as the community has grown, the healthcare has had to grow. But on the other hand, at this time, healthcare's never been more complex, more complicated. And in this way, Salem Health is an organization that works very hard to respond to the needs that you have right now. And you don't understand, I think, how significant your involvement is in this until you don't have a way to be involved. And that's why I'm so glad that so many of you are here. Being here today is being involved. Going to your doctor is being involved. Tolerating a wait on a telephone line is being involved. We want to always work to improve all of that kind of stuff. But local health care provided by local people, controlled and operated by local people, is a very important thing that you have been building, and we don't want you to lose that. You don't want to be making a decision in Dubuque or someplace else when it's important to make the decision that's right for here. So that's my message, is we're all local people. We all care about having access to health care locally, and you're in the driver's seat to continue to do that. So today we're going to talk about fentanyl, the fourth wave, this incredible drug. I want to point out a couple things to you. On your table is a little flyer, and there's a mistake, and it's one of those things where you've looked the thing over 25 times and you don't see it. But I want to recognize that on your flyer, when you see Nancy B's name there, it's an MBA, not a BBA. And having gotten an MBA, you earn that, so you don't want to lose that. So please take your pens out and correct that BBA to an M. Then I'll feel a lot better. The other thing I think it's important to point out is on your table is some information about fentanyl-free Oregon. There's a table in the back about fentanyl-free Oregon. There's a website that's fentanyl-free Oregon. There's a QR code that will take you to fentanyl-free Oregon. That's an organization that was created here as a part of this community health impact work to be a resource for people about the fentanyl issues. And it's continuing to grow. We've got billboards up. Anybody seen the billboards? I see, yeah. So we've got billboards up all over the region. We've got banners and posters. We're at a lot of the major public events. And the point is to get the information out about the risks that are related to this fentanyl drug. And they are real, and they are going to continue. And I think when you hear our speakers today, you'll understand how interesting this really is and how it's affecting our society. So I'm not going to speak any further. There will be a Q&A at the end, and we'll have, as you see, we have 2 mics. So if you have a question at the end, it'd be easiest if you came to the mic. If there's a little line there, that's okay. The speakers will answer the questions at the end. So what we'll have is three presentations. They're interconnected, but you'll see we'll start with Chris from HIDTA. We'll move to Dr. Olson, and then we'll finish with Nancy B. from Salem Health talking about local information. So without further ado, I'd like to introduce our speaker today. Chris?
I just maneuvered the first obstacle, and that was not falling off the stage in front of all of you. So hopefully things will just get better from here. As Jim mentioned, I'm Chris Gibson. I'm the Executive Director of the Oregon-Idaho High Intensity Drug Trafficking Area Program, which is HIDTA for short. Just want to give you a really brief overview and explanation of what HIDTA is. It's a White House Office of National Drug Control Policy counter-drug grant program that provides additional federal assistance to state, local, and federal drug enforcement task forces throughout the country. There's 33 HIDTAs in the country currently. We've all got different budgets, but the HIDTA program has a footprint in every state, plus the District of Columbia, Puerto Rico, and the U.S. Virgin Islands. So we're an expansive program that provides, again, federal resources. Our local mission here is to basically facilitate and coordinate and partner with drug enforcement teams throughout the state, but we also have a footprint within the prevention and treatment and a little bit less, in the harm reduction community. So that's where we're at. Clicker. Okay, I missed the second obstacle with the clicker. As Jim mentioned, this is about fentanyl today, but I'm going to talk to you about another drug, and these things are all very closely related, and we'll get to that here in just a minute. But talking about fentanyl, the question we always get is, how does it get here? Where does it come from? And the bottom line is it comes from Mexico, and the way that it is produced is there are precursors. This is a chemical-based drug, nothing natural about it. Chemicals that come in from China mostly to Mexican drug cartels located in Mexico. They produce a varying degree of different types of drugs, fentanyl being the one that we're going to talk about mostly today, but also methamphetamine as well. And these things are very closely related. So once a finished product is put in place, there are mechanisms by cartels to get it to the border and eventually get it across the border so that it can be moved, in our case, up the I-5 corridor, oftentimes after stopping someplace in the States, getting redistributed where the business model takes care of the logistics piece of it, moved up the I-5 corridor and into our communities, and that's where you're seeing this come from. Once it gets into our communities, it's usually divided up amongst organized drug trafficking organizations where they've got kind of a retail model that they will then begin moving drugs to. This is all about the money. Once the money is made, it gets cycled back through and either laundered through businesses or through money remitter businesses. Oftentimes those are the two ways, but that money eventually makes its way back to Mexico at an extremely high profit because fentanyl is extremely cheap to make and extremely cheap to the users, but made in extremely high quantities. So that's where we see it come from. I'm sure there's plenty of questions afterwards about some of the more specifics about that, but from a 30,000 foot level, that's where we see this drug come from. Fentanyl in our state, we see it primarily in 3 different forms. The first, which you've all read about, are counterfeit pills that resemble oxycodone 30 milligram pills, which are then distributed into the community amongst users. A lot of reasons for that. I'm not going to get into it for time purposes. We're seeing an increase in the amount of powder that's coming in as well, and we'll show you some numbers on how that is actually working. Most of the pills that are being found are pressed in Mexico and transported up that I-5 corridor, as I mentioned before. Again, we're seeing more powder coming into play, and there's specific reasons for that, primarily because the user base is used to the pills now and want to be able to provide their own doses through the powder format as well. Occasionally, we're seeing pressed powder as well. You've probably heard several years ago about rainbow fentanyl. These are all pictures of those 3 types of forms. thing I failed to mention is the HIDTA program is required every year to write and put out an overall drug threat assessment for the area, which helps to drive our strategy. And we do this every year, and this is where a lot of this information comes from. We try and gather as much from as many sources as we possibly can to start looking at things. Most of what we're going to talk about here in my few minutes is drug seizure data. Going backwards, at the beginnings, we like to look at what's happening along the southwest border. What are law enforcement agencies seizing there? Because it's often more real time than what we can get here, and it's the first wave that we see coming into the country, so we continue to look. Fentanyl pills are displayed up at the top. I'm not going to get into numbers specifically. Please pay attention to what those trends look like. Upward numbers all the way through. Then on the right side are our HIDTA numbers. We've got 17 enforcement task forces scattered throughout the area, and those numbers really kind of end up mirroring what we see along the southwest border, and for good reason. What they're not getting is making its way up to us, and our law enforcement partners are coming away with those. So one of the things that I wanted to note here along the southwest border, you've seen a decrease in the number of pills. The last column on the right is through the first 3 quarters of the year compared to the full previous year. We're seeing a downward trend in the number of pills that are actually being seized at the border, and that's reflective also within our area on the chart on the right as well. Although I think our numbers are going to be really close to what they were the previous year, but as you look back to the left, that's kind of a leveling off of what we'd seen from 2020, even before that in 2018, where we began seeing those numbers. I mentioned before powder fentanyl, which we're seeing more of all the time. And you can see also along the southwest border, 2023 was a banner year for the amount of powder that was seized. When you look at the trends through the first 3 quarters of the year, that may have reduced itself a little bit, but please don't think that we're anywhere over the hump at all, because we're not. Pay attention to what happened before. We want to get our numbers back down to near zero if we possibly can. On the right side, we've also seen a dramatic increase. In fact, the rate of increase is much higher for powder than what we see at the beginning, than what we saw at the beginning when pills were first making their way into our area. The red lines I failed to mention are the number of actual seizures that are occurring. When you see those numbers go down, but the amount that's coming up, we're seeing a lot bigger seizures that are coming through. Multi-kilos of both pills and powder as well, almost on a daily basis from our law enforcement partners in state. I wanted to break it down just a little bit more for basically Marion County. Marion County is one of the 12 HIDTA designated areas. We've got one task force here that is DEA led and is also participated on by the Salem Police Department. And so these are the numbers that we can see, at least from a HIDTA perspective. None of these take into account the numbers of seizures that are made or the amounts that are made by local law enforcement doing patrol work. But I would venture a guess to say that those numbers weren't very great, especially over the last 3 or 4 years, but we'll see those start to increase a little bit more if we were able to grab those. This is powder and pills for 2024 in Marion County. Almost, I would venture to say, almost no pills have been seized. I think that number is about 7,200, but on the other side, almost 13 kilos which is about 26 pounds of powder has been seized by law enforcement, while the number of seizures have actually gone down across the board. Mentioned before, methamphetamine. I don't want us to lose sight of the fact that methamphetamine continues to be a huge problem here. While it's not produced locally, it's also produced in Mexico and transported across the border. Oftentimes we will see loads of combined, and when I say combined, separately packaged methamphetamine, fentanyl, cocaine, and heroin, or some combination of those. That's because there are 2 cartels on the southwest in Mexico that are controlling the distribution and entry of all of these drugs. It's the Jalisco cartel and the Sinaloa cartels, which really control the majority of what it is that we see coming into our state and our region. Methamphetamine seizures, I would say that those have never really dropped off very much in the time that we've been gathering those numbers. It's a pretty consistent amount that is coming into our state and is being seized by law enforcement. When you look at our numbers in the Oregon-Idaho HIDTA region, we've actually seen an increase this year through the first 3 quarters. 2021, we saw a record amount. Already through the first 3 quarters of this year, we've seen an increase of 15% between that record year and 34% increase between this year and last year. So we're really concerned about the amount of methamphetamine that's continuing to be produced and making its way into our area. Really quickly, in conclusion, last year, I believe there were about 1,400 recorded overdose deaths in our state, which was a record number. Through the first quarter of this year, the last number I saw was about 350 overdose deaths this year so far. While that number doesn't trend out to be a record year, one life is way too many, especially when it affects a member of your community, a member of your family. So we're working tirelessly to work on all fronts to alleviate the problem, or at least lessen it as much as we can. So when I talk about seeing those leveling offs, please don't listen to anybody who tells you that that's a success. It's not a success. It continues to be a problem that we need to focus on directly and continue to focus on and continue to come up with initiatives and strategies to reduce those numbers across the board. In conclusion, we also work with our crime labs to kind of see where or what drugs are being seized by law enforcement and tested. Pretty decent margin. Most of it is methamphetamine, followed by fentanyl. When we start looking at, because there's a lot of questions about how much fentanyl is tainting the drug supply, while we talk about it a lot, our numbers just aren't bearing out the numbers that people are telling you. And when I talk about tainted drug supply, it's deliberate mixing of fentanyl with other drugs. We're continuing to watch it, but we're not seeing it in as great a numbers as before. Of all of the seizures that have been evaluated in Oregon during this year, about 12% of those came back positive for fentanyl plus another drug. Oftentimes, well, about 49% of those times it was fentanyl combined or tested positive along with methamphetamine. A lot of reasons for that. We know that there's a lot of polydrug use that's occurring. We can't go back and look to see where those drugs were actually seized, whether it was cross-contamination, deliberate contamination, or it was a user that was using both of those drugs. But those are things that we're seeing quite a bit as we continue down this road and we continue to assess what impacts fentanyl and the drug supply are having on our qualities of life and lives of the members of our communities. With that, if there's any questions at all, my contact information is up there. If you're interested in seeing our threat assessment, we're more than happy to send that to you electronically. If I just get an email from you or business cards dropped off today, I can get that to you as well. So thank you.
All right, that means I'm next. So my name is Kelly, and I am the Director of Clinical Affairs with a laboratory called Millennium Health, and we're the largest specialty toxicology lab in the nation. And so I am honored to be here with you all and to share some data with you. With what Chris had presented, I want to make sure what I present to you guys is a little bit of a zoom out, looking at a 30,000-foot view of what's going on in our country. And then Nancy's going to come back in and really zoom back in with what's going on here in Oregon, and especially in these counties that you all know and love. And so I'm going to zoom out just a little bit. And I wish I had a Canadian language translator. So zooming out, oh, there we go, my fellow Canadian. That's great. That's great. So what I want to start with, first of all, I started my career in law enforcement. And so I was Border Patrol for about 7 years. And clearly I wasn't very good at it. I only lasted 7 years, but I went into medicine after that. And I remember looking at addiction and thinking and seeing it completely different. So when I was in law enforcement, and again, no shade on anybody, I just didn't know. I didn't know beyond protecting my country, protecting my colleagues, protecting I had no idea beyond that what it meant to an addicted brain. Then I got into medicine and I realized it was like an iceberg. I was only seeing the tip of the iceberg. When I went under the water and I looked at what was happening with the brain, I realized that addiction just goes so much deeper than what I could have ever imagined. And so when we look at this, and we'll just go through this really quickly, because I do have a number of slides I just want to make sure we get through, but I want to start with how we got to where we're at. It seems to me that it's a trajectory, of potency. And what I mean by that is follow along just with the colored boxes. So time is on the x-axis. So about 2000, 2001, all the way through to the end of 2022. And one could argue even into 2024. And we'll cover some of that data as well. Look at the y-axis or the upright. That's the number of overdose deaths that were counted at that point. Okay? If you look at the pink box at the bottom left, that's what we would consider wave number 1. And what that constituted was natural and semi-synthetic opioids being the primary driver of overdose deaths around the late 1990s, early 2000s. So some of you may have heard, or maybe you've had a family member who said, you know what, in high school I played football. And honestly, I don't know why they wouldn't play hockey. But anyways, regardless, they played football and they got an injury and they went to their doctor and the doctor said, here you go, here's a prescription. And that prescription happened to be an opioid. And in some cases, sometimes a pretty powerful opioid called oxycodone, which Chris introduced you to in a counterfeit way, but very similar to what the pharmaceutical looks like. And that pain subsided. The pain perception subsided, but in some people, they really liked how they felt when they were on that substance. That's a big deal. Now, I had surgery a couple years ago, and of course, my doctor decided that I needed pain medication, so I fully expected something like an ibuprofen or hydrocodone, but no, I got oxycodone. And I thought, all right, I'm going to put my scientist hat on, if you can believe that. I'm in pain, and I'm thinking about science. But I tried it, obviously, to stay ahead of the pain, and I did the prescribed, dosing, medication, etc. I hated it. I hated how I felt. It was awful, nauseous, it was terrible. But imagine that on the flip side, where you feel really good. So you can well appreciate how much of a draw some of these opioids have with certain folks. It's something that, again, just feels good. As we progress and we go to the right of that particular slide, you'll see wave number 2. So as time went on, heroin unseated natural and semi-synthetic opioids as the primary driver of overdose deaths. And we know that. You can go back and you can look at famous people, musicians, etc., who all either utilized heroin or died from a heroin overdose, that really took the primary driver's seat back in about, the early 2000s, 2008-ish. By the time 2014 rolled around, we had a new substance in the field. Now, this is not the prescribed fentanyl that we've heard of in the past. These are completely illicitly manufactured fentanyl, as Chris was mentioning, by cartels that are supplying the country. Well, if you look, 2014-15 is really when that substance took over that driver's seat of overdose deaths. Now, if we were to put another box in the top right-hand corner, Chris alluded to this, that would be fentanyl plus. So everything from fentanyl plus methamphetamine to fentanyl plus xylazine, which I'll cover a little bit, to fentanyl plus carfentanil. You've maybe not even heard of that substance. anything that you can get to mix with powders or crush with tablets, whatever you can get your hands on. And in some cases, the clients don't even know what they're taking. So my understanding is from some of my contacts, a friend of mine, I got to be careful how I say this, but a friend of mine was part of one of the cartels. And I've said this before, and I've said a friend of mine in the cartels, and I almost got pulled off the stage. So I'm very careful now how I describe him. But he was part of the cartel agency, one of them. And what he told me was a lot of times even the street dealers don't know what they've got. So when they're selling it to their client, to their customer, they may not even know what they're selling. And so the mid-levels are the ones that tend to be the mixers. They know they are starting to push for demand. So a lot of times our clients, our patients don't know. But Chris had also mentioned methamphetamine. So let me just quickly transfer my information now to that. We know that the illicitly manufactured fentanyl is very, very potent. Chris had talked about a little bit on methamphetamine. And we know that methamphetamine is more potent now than it's been. Certainly has jumped up and down in terms of purity, but it's the combinations that we're seeing that are really, really, really scary. If you look just specifically at the right or the left-hand side, the red box that you see there, today's methamphetamine, back when I was on the border, we were looking for methamphetamine and marijuana, but we did not have the potency of methamphetamine that we do today. And again, you know this, you may have family members, you may be working with people that have an addiction, but that drive to get high is so incredibly strong. But you mix something that's as strong as illicitly manufactured fentanyl or methamphetamine, or sometimes both, and now you've got an absolute ridiculously tough time to push through when looking for recovery. So look at the left side. When we talk about today's methamphetamine, we would be remiss if we didn't talk about some of those negative health consequences that a lot of times we don't even think about. Things like increased cardiovascular issues, heart palpitations, stroke. We also need to talk about a lot of the psychosis that results from the use of today's methamphetamine. We've had folks that have been in recovery for 10 years, and they said they're very, very frightened of the methamphetamine today. So we have to make sure that we always kind of bring in the collateral as well and look at some of the negative health consequences. Now, one thing just quickly about psychosis, I want to just impress upon you that the psychosis that we've maybe heard tell of, or maybe we've seen, especially if we're in the medical field, it's different too. So much so, and this may surprise you, but the psychosis oftentimes is lasting 18 plus months. And in that, as if that wasn't bad enough, a lot of times during that time, there's no lucidity or chance of stability where any kind of a therapy can be added to assist. And so we also have to take into account what the client, what the patients are going through when they can't even stabilize. So that is something that I wanted just to remind us about, that it's quite different than what it used to be. Now, this is an animation. And I feel like a meteorologist, because this is one of my favorite slides that we've ever produced. And you'll see what I mean by being a meteorologist. And I know I wouldn't do very good at that either, but let me walk you through what you're going to see. You're going to see on the black banner at the top, time changing from 2013 all the way through to the end of last year. You're also going to see that each of the states will be colored based on what we saw as the primary substances at the time in those states. The states that don't have a color, please don't pack your bags and move to those states thinking that they don't have a drug problem. They indeed do, but we just didn't have enough data from those states to be able to count it. So watch when I go through this, and I'll tell you the different colors, what they mean. The red that you're seeing there right now, basically across the United States, are fentanyl-positive urine specimens with non-prescribed prescription opioids. Now that sounds like an oxymoron, but it means that that prescribed opioid was found in that person's urine, but they had no prescription to accompany it. If you see yellow, that'll be fentanyl positive with heroin. Orange will be fentanyl positive with methamphetamine, and blue, fentanyl positive with cocaine. How they got into the urine together, separate, we don't know, but it was in that urine specimen. All right, so let me just start the animation. Watch the color changes over time. You can see a lot of that fentanyl positive with heroin coming in from the East Coast, which we're very familiar with. A little bit of fentanyl positive with meth in Washington. You can see the advent or the start of fentanyl positive with cocaine on the East Coast, 2019. Look at it really taking over a large portion of the country as well. And by the end of last year, and I argue also into this year, we went from opioid to opioid stimulant as the primary combinations of substances. And you can see so much so that it looks almost like a turf war halfway through the United States, meaning that a lot of this stimulant is flooding our country as well and joining up quite handily with fentanyl. So I wanted to show you that just to kind of give you an idea of where those combinations are now and how we got into that place. Now, the one thing I want to mention to you, as of last year, and as a matter of fact, I just did the analysis for this year, if you look at the top bar, it will say methamphetamine. If you can see it in the back as well. What I want to point out to you is that last year, when we found fentanyl in a urine specimen, 60% of the time, we also found methamphetamine. That's astounding. Do you know what it is today? About 65% across the United States. And this is where Nancy's going to come in and she'll be able to, again, give you some more local information. But that was astounding to me. And then third on that list is cocaine. So every time we found a fentanyl, about almost 23% of the time we also found cocaine. So opioids and stimulants most certainly rule the roost, so to speak. And if you look at the colored box there, about 7% of our specimens only contain fentanyl by itself, only 7%. And there was over 4 million specimens that we tested. So that, in and of itself, is also a telling tale, that we are looking at a crisis of co-positivity, led by, of course, fentanyl. So I wanted just to bring that to your attention. I have a couple more things that I just want to briefly touch on before I pass the mic over to Nancy. I want to just tell you a little bit about a substance called xylazine. Chris made mention of combinations of different things, fentanyl and. I talked about it in that first slide. There's a substance called xylazine. Now, I don't know how many of you have heard of it, but it is, in fact, an animal tranquilizer. It's not an opioid. So if utilized with an opioid, you can see where I'm going with this, Narcan does not appreciably work to reverse it. But what's so interesting about this substance is it found its way into human use, specifically with an opioid, primarily fentanyl. Now what it's doing is it's giving fentanyl legs. Now for those of you that don't know what that terminology means, I certainly didn't, but it means that it can extend and or enhance the high. So what that does is, for the consumer, it allows them to dose less often. So you can imagine you're getting that same high, but you're having to dose less often. The cartels are still making their money, but now you're appealing to the sensibility of the customer. And you can see that the darker the red, the greater the positivity or the greater the percent change over time. We started testing for xylazine last April, so April 2023. So it's been over a year and a half now, but already up and down the western seaboard, that combination, fentanyl positive with xylazine, increased almost 150%. Now, is it taking over the drug trade? Absolutely not. But I wanted to at least mention it to you very, very quickly. The last thing that I want to show you is something called carfentanil. Carfentanil is also an animal tranquilizer, but this time it's an opioid. Now, it has no human use whatsoever, but it too has found its way into the drug channels. And if you were to dump over a salt shaker on your table and take just one granule of that salt, that would be enough fentanyl for most of us to succumb to be a lethal dose. So that's how potent this substance is, about 10,000 times more potent than morphine. So it gives you a massive view of the potency of this. Now, we're starting to see an uptick toward the end of that slide to the left. You can see just before that COVID declaration, which is that red dotted line that you see vertically, just before then we started to see an uptick. After that declaration, basically zero. But it's starting to creep up again this year, and we wanted to make sure that you were all aware of that combination. Again, a lethal combination. Now, this is basically where we're seeing it across the United States. There's already, this is out of date, and it was published in June, there's already 4 more states that have shown those positivity. So basically what this is telling us is that it's showing where these substances are going. It's pushing that potency, decreasing the cost to get it out into drug channels, and making the cartels an awful lot of money. So with that, I wish I had better news, or I wish I was funny or something where I could leave you with a joke, but when I bring Nancy up here, she is going to have so much information about the local sort of drug trade, if you will, the local flavor, the local landscape, and I think it's really going to hit home. So I want to thank you for your attention. I'm going to bring Nancy up now and have her do some of the local stuff. So thank you, everyone.
Well, thanks, everybody. Thanks for being here today. And just as Dr. Olson said, we're going to bring it back home a little bit closer to specifically our state and our area. So here's some headlines just from this year that are easy to Google. And what you can see in these headlines is that fentanyl is found in our families. It's being exposed to our children. It's in our correctional institutions, and it's even in my workplace, if you will, in the healthcare industry. One of the most tragic things for me personally was a hospital down south of us in Medford that had to report off to the national media about nurse using in the hospital. So this illegal drug use shows no bias, and it is going to hit and has hit every possible demographic of our community. This data is from the Oregon Health Authority, and it shares the emergency and urgent care visits from the centers that report to the OHA. So these are not 100% of facilities. We use this for trending, not actual numbers. And what you can see is the trends of visits from 2022 to 2023 have significantly increased, and then the green line from 2024 has started to decrease. Again, similar to what my colleagues have shared, we would almost get some hope, but this actually tells me that what's happening is people just aren't seeking help. If we do overdose visits by county, and when we look at the map, you can see here the I-5 corridor is the hot counties, if you will, and Marion County is in the top 4 counties, only outdone by visits in Multnomah County, which is the top darkest blue. Go back. There we go. Now, closest to home at our emergency department, our total overdose visits increased 40% from 2022 to 2023. And in that year, I have more sad stories than I could possibly share up here. We project only an 8% decrease of visits from 2023 through 2024, but we have seen and will see a small decrease. Now, when I pull out specifically our opioid and fentanyl visits, that's where the data becomes even more telling to what's happening in our community. We do see the sudden increase of fentanyl overdoses in 2021, as you can see there. And most of those visits from that year and continue on are really unsuspected users. The users, when we ask them and tell them that their urine drug screen was positive for fentanyl, they'll say, I was just buying cocaine, I was just buying meth. They did not know that they were buying fentanyl at the time. As shared, the cartel is in the business, as many, if not all of you are. So how do you decrease cost of making a product, make your product better, and increase your market share? And that's what they did with fentanyl. Cheap to make, better high, grab more people. And that's what we see in the overdose visits when I look at just specifically fentanyl in our area. Now, looking at the data by age, data has actually changed quite a bit as well. So from 2015, our 15 to 24-year-olds, that's the gray bar, they held the highest and they led us in overdose visits. So they were coming to seek us for help specifically. In 2023, for the first time, our 25 to 34-year-old population, that would be the yellow bar, exceeded our younger ages, and our 35 to 44-year-old group increased 60%. So as we track this data, and I don't have details to share with you, but here's what I can tell you anecdotally. Our children aren't getting the help that they need. They're still in trouble. The market expanding that I just shared with you is real and true, and they've grabbed more of the market than they had before. And finally, I want to be clear that within this data, sometimes there's an assumption that this is the unsheltered living under our bridges, on our sidewalks. And that's true. That's true. If you start to use drugs, the spiral's pretty steep, and often end up unsheltered. It's also very traumatic to be on the street, and so a lot of people use drugs to deal with that trauma. But be very open, please, that in this data is a D1 high school athlete, senior football player that overdosed and died. It's a mom of 3. It's a business owner. It's the churchgoer. It is every demographic. It is not just our homeless population. So while these are visits, there's the group that we actually couldn't save, and we can move now to the deaths. I showed you how in 2023 the total overdose visits increased, and in 2024 they were decreasing. However, the death rate from unintentional overdose is far from improved, and 2023 has outpaced deaths than any other year, and 2024 does project to be in the same footsteps. And when I pull out deaths related to opioids specifically, you can see here that we're trending in all the wrong ways, and which is why we're very, very grateful you are here today to listen and learn, and please share the information. Finally, from our Oregon State Crime Lab, just another set of data that supports what we're seeing here is a state and in the hospital. From their lab, when they test postmortem cases, they have a significant increase in fentanyl, that's the blue line, being found in deaths of cases that they are testing at the state crime lab. Now, Chris went over gave you some pictures of what fentanyl looks like, and Dr. Olson shared how a tiny little grain, 2 milligrams, is what's considered lethal in the fentanyl market. I put up there some slang, because part of this is education, so you can listen and learn, your family, your neighbors. The most common slang I hear, although Chris would be definitely more the expert in this, is blues and fetty. The street fentanyl, the illegal fentanyl, is made dirty, I call it. It's made in these vats. There's one of the recipes is called a one-pot recipe. So it's very dirty, has a lot of byproducts to it, which is very different than the fentanyl that I give or would give in the hospital setting. There is a pharmaceutical-grade fentanyl that is amazing. We give it all the time in the acute care setting, and it feels different and is very different from what you buy on the street. So what you buy on the street, or what a user would be buying on the street with those byproducts, the fentanyl sits into your pain receptors, and it means that it's sticky. It sticks in there longer, which is why when the medicine I give in the hospital lasts about 5 to 15 minutes, the fentanyl that is on the street can last hours and even days. So it's very, very different from what the fentanyl you would receive in an acute care facility. Some signs of overdose, these are going to track where your pain receptors are. So you have pain receptors in your brain, you have pain receptors in your lungs, and you have pain receptors in your gut. So in your brain, when you take a narcotic, you feel better. The pain receptors in your brain are blocked by the narcotic, and you can feel euphoric, or ideally the pain goes away, or you're high, if that is the intent. Then if you take too much, you could become unconscious. The pain receptors in your lungs will decrease your breathing rate, and as your breathing decreases, you could get a gurgling sound. That's one of the signs up there. And then eventually stop breathing, and when you stop breathing, the lack of oxygen is going to change your skin color. So if you were in the community and you were seeing some of these signs, it could be that somebody is overdosing. To briefly touch on xylazine, as Dr. Olson shared, this drug was first synthesized in the 1960s, and not an opioid. It's a sedative, a tranquilizer, muscle relaxant. It's only used for veterinary use and not approved by the FDA for human use at all. In fact, the first known user is a veterinarian's wife in 1980s that is documented. So just as the cartel added fentanyl to their product to expand it, that's what they're doing with the xylazine. The drug takes an effect in about 1 to 2 minutes, and it lasts about 4 hours. On the street, it's called trank dope, zombie drug. The zombie drug comes because of the tranquilizing effect. People will have a hard time standing up, and so they bend over, as that picture up there shares. The telltale signs for us in acute care is going to be the wounds that are actually created. This drug makes the normal, healthy, if you will, non-diabetic person almost immediately diabetic. Their sugars go very, very high. Their insulin resistant goes really low. So any place that they even have an active wound or even a healed wound will become what we call a diabetic ulcer. They really fester and they get these really, really awful wounds. And those are the pictures. It's a poor picture down there. My other pictures are extremely gross, and you were all going to be eating lunch, so I wasn't going to put those up there. And then this is a lady who had her wounds actually healed. So exactly as Dr. Olson shared, the drug users will say that xylazine gives the fentanyl legs, or the drug legs, and makes it feel more like heroin, which is why they're using it. Now, Narcan is a drug that you likely know a lot about because it's talked about a lot more in the last couple of years, which is great news. And Narcan's job is to reach into that pain receptor, pull out the narcotic, and sit in that pain receptor to prevent the narcotic from being there and reverse the signs of overdose. But remember, the fentanyl that's on the street is dirty. It's, again, I call it sticky because I don't have another non-medical word to use for it. And so it can take a lot of Narcan in order to release that fentanyl from that receptor. So you'll hear stories of medics having to give 10 up to even 20 doses of Narcan to free that receptor from that drug. Where in the acute care setting, the very, very few times I've had to give Narcan, we give it like a sniff. It's just a little bit, and the person will wake up because, again, the pharmaceutical fentanyl we give is so different. To deliver the Narcan, you just ideally tip the head back. It's a nasal spray. You push it into their nose, lay them back down or roll them onto their side. So if they were to wake up or they get sick, they're off on their side so their airway isn't occluded. Please call 911. Remember, 1 dose might not be enough, which is fine. You tried to give 1. That's great. If you have another one, you could repeat it. And then always remember CPR. So if you don't have Narcan, you can deliver CPR, and it can help until medics can arrive. Finally, a list of suggestions. So, as we discussed when we started the first wave, it was all about the idea that life should be pain-free, and procedures should be pain-free, and surgery should be pain-free, and that's just not how it is. So as you go into a procedure, you're going to have a surgery, or a family member is being aware that there's going to be some discomfort with those things, and trying the non-narcotic ways first. So ibuprofen, Tylenol, ice, heat, all the things that we give you, they really, really do work. And so changing our mindset to doing something different than narcotics. We limit the number of narcotics we give in the hospital setting and in the doctor's office. So back in my early career, it wouldn't be uncommon to send somebody home with a prescription of 90 OxyContin. That doesn't happen anymore, thank goodness. You can get Narcan over the counter, and you can also get prescriptions for it. The doctors will do it. Watch for signs of overdose, and then the wounds are what we're looking for related to the xylazine. It's really important. I implore you to please, not only yourselves, but teach your children and your nieces and your nephews about not taking a pill that's not theirs. So how this looks for me, I have 2 kids at South Salem High School, and my daughter gets a headache, and she calls me at work, and she says, "Mom, I have a headache. Can I take ibuprofen from my friend?" I know this friend. The girlfriend that she's talking about is lovely. I know her family. They are wonderful. And I say, absolutely not. Absolutely not. You can come to me at work. You can go home. But we take medication from bottles that we know that we bought. We do not take medication and share pills between each other, especially our children. Please lock up your medication. This is very important, especially if you have young children or grandchildren in your home. Please make sure all your medication is locked up, especially around recreational marijuana, whole different topic, but please make sure that that is locked up. Children get into gummies and brownies, and we see lots of very young children under the influence. We talked about CPR, and more about children. Vaping is definitely the drug traffickers' gateway into our kids. So if you hear of a neighbor kid, somebody in your life vaping, I would stay attuned to that. And Benadryl and Imodium, over-the-counter medication, also can give a high-like effect. So some children and users have figured this out. So if you find, while you're searching backpacks in rooms, which I highly recommend, if you find boxes of these drugs, you've got a problem. And I would just recommend you go seek expert help for your child or whoever you're concerned about. Finally, social media. Most of the kids that live when they come in for an overdose in our emergency department, and we ask them where they bought it from, that will share. Every single one of them is off social media. Snapchat, Instagram. The drug dealer will deliver to their window at 2 in the morning. So putting limits on social media, checking the phone, which if it's a phone that you own, it doesn't matter that my kids are 16 and 17 and have their own phone. It's my phone, and I take it all the time and look at it, and they're good kids. I just want them to stay good kids. Of course, you can imagine they know this story way more than other kids do. But thank you for being here, and thank you for having us, and I think we'll have some time for questions, and I'll pass back off to Jim.
So we have 2 mics. One here and one here. And ideally, if you could just go to the mic and ask the questions, our experts will try to answer that for you. Before we get started with that, I just want to make a plug again for Fentanyl Free Oregon. If you're interested in getting involved in putting up a banner, having a yard sign in your yard, at your business, that just talk about the Fentanyl Free Oregon movement, we've got them available, as many as you want. I promise you, as many as you want. Fentanyl Free Oregon just got permission from the Salem Kaiser School District to start putting that message into the schools. Thank you, Andrea, and the team at the school district. That's not as easy as it all seems. We've been involved in a lot of public events, the fair, pretty much every festival event this summer. Fentanyl Free Oregon has been there. But right now, it's the easy place is it's a website that you can go to get resources. If you go there, if you hit the QR code, you can say, I'm interested in this, I want this, can you help me with this? And it's a vessel that we can use to get that information back to you. This slideshow presentation will be on the Fentanyl Free Oregon website as well, so if you want to go back and refer to anything that's happening, we'll have that available. So I know we're on time, so I'm, okay, we're trying to, well, they nailed it. They're very disciplined. Perfect, perfect. So we have a question, and we'd love to have more. We'll start right there.
Thank you for sharing. Two things. What is the primary DTO here in the Mid-Valley? And as citizens, what are we looking for? In other words, who's really distributing this stuff here locally? And then what do we look for as a citizen? How do we recognize DTO activity? And obviously we know to call 911, but what can we do to help get these idiots out of our community?
Who wants that?
So the question about who the primary DTOs are, I'm not sure that I can give a great answer for that, especially in this community. But what I can tell you is that annually our enforcement groups are identifying upwards of 75 DTOs a year, and then they work to dismantle and disrupt those DTOs that are present. So it's kind of an evolving, always the pressure that's on them. They're changing all of the time. As to what can we look for as far as DTO activities go, it's as simple as, if you're living next to what you believe is a drug house because you've seen a lot of activity that's occurring that resembles drug activity, people coming and going, short stays, hand-to-hands out in the parking lot, those types of things. I can't stress enough to call the police and let them know what it is that you're seeing. They may not be able to do something with that observation of yours, but they will give you instructions based on the scenario to maybe keep tabs on things, taking license plate numbers, tracking times when people are coming and going, and they'll get to those as they ultimately possibly can. Unfortunately, in our communities all over the place, I wish that we had more resources to be able to actually do the drug enforcement side of things, but law enforcement numbers are down. The ability to staff these task forces are always going to kind of be the first hit when it occurs. So continue to support your law enforcement groups along these lines are where it really matters. Information sharing amongst law enforcement groups is at an all-time high, and that makes a big difference for us too. So breaking down some of those barriers between agencies.
DTO, drug trade organizations, drug trafficking organizations, in case anybody's working on that.
Thank you. So in the 80s, we had the war on drugs, which I don't think really got us the results we were looking for. Curious your thoughts on how we learned from that and how we approach this new crisis.
Anybody?
Well, in the 80s, I was not in nursing yet. I know. So I don't know that I'd be interested in what you all think. I don't know that we talked about it as much as we talk about it today. And the drug was different. It was a party drug back then. When we outlawed ephedrine, meth changed to be the hood over almost immediate psychosis. So the drugs just look different, and we just have to keep talking about it and doing something different. I will say, from my perspective, make drugs less accessible and make rehab and help more accessible. And for that, we need everybody's help. Is there something anybody want to add? Yeah.
I was just going to say I agree with that too, and I think the landscape was different, certainly, and I think the catchphrase, just say no, I think that was wonderful, but it just fell on deaf ears for a lot of people. Don't tell me what to do, or that's not going to happen to me, and it's the same thing when you fast forward to today. A lot of the kids, a lot of adults are thinking the same thing, but to Nancy's point, the drugs are different now. It's not let's just try this. Let's just have some fun. Let's just see where this goes. It's literally one pill can kill. So the education, the exposure, or the ability to get somebody into treatment when they are ready, not 3 days from now or whatever, I think that's a crucial piece to this too, and a difference than what we had back in the 80s.
I want to add one thing too, because I absolutely hate that term, war on drugs. It wasn't a war. It's never been a war, but what it's been has been an issue that affects all of us. And what has happened on the enforcement side specifically is, in the 80s, you would have never seen the three of us up here talking together about an issue like we're talking about now. On the law enforcement side, the HIDTA program was a response to that piece of it, where we bring different agencies together at the federal, state, and local level to share information. We've got mechanisms in place because we know that drug dealers, DTOs, aren't just operating in downtown Salem. They're supplied by other parts of the state, other parts of the country, and internationally as well. The other thing that I think that we've done even a better job at doing is, one, we realized really early we're never going to arrest our way out of the problem. We've also realized we're never going to be able to treat our way out of the problem. And I'm hopeful that someday we can prevent our way out of the problem, but we haven't caught up to that as far as a resource allocation piece of it goes. But together, sharing information from all of us, sharing information about the drug supply, what we're seeing, obtaining information from the medical community about what the impacts are, help us to create strategies that I'm really hopeful about. Are they going to be quick and simple? Are we going to come out here next week and the problem's gone? No, it's kind of like I always love this, turning an aircraft carrier around in the middle of the Willamette River. That's not going to take. That's not going to happen very quickly, but we've got to continue to move forward and don't get a false sense of security when we see things like drug seizures going down or overdose visits to emergency rooms going down. That's just where we need to actually start putting those resources to play.
My question goes back to Nancy's statement about accessibility of treatment. So I've heard recently that Salem Health may no longer accept Blue Cross Blue Shield. And so can you give an update on that and how you are addressing that potential impact to accessibility of treatment?
No. I actually can't. I'm not the expert on the benefits and the contracting side. Here's what I can tell you from working within the system is we want to treat everybody and we want to be there for everybody. On the other hand, also all of us are a business. So Salem Health is, from what I know, is doing all they can to make sure that contracts are fair between all different groups. And the goal is that we were there for everybody. But I'd have to refer you back to some of my colleagues for that answer to that question. Thank you.
Dick?
Yeah, Jim, as a society, we did a really good job on smoking, because that creates cancer. So it seems like drugs and dying would be a little bit in the same emphasis, but is there a possibility to get a message out that, as what we did in the 60s and the 70s about smoking?
Anybody want to take that? I think that there are, one of the things that we see in this is that people don't understand the risk that is associated with this drug. And I think there is a correlation, as you described, that people for a long time didn't see the risk in smoking, and then they began to understand it, and it started to change the behavior, but it didn't end the smoking. And so I think we're going to be continuing to work on the risk side of this for now. Because right now, I don't mind saying this, I was a recreational drug user in the 70s and 80s, and I had no fear at all of virtually anything that they threw in front of me. And, I praise God that I lived through that, but that's not the way it is today. This really is a serious situation of you take the wrong pill at the wrong time, you take the wrong powder at the wrong time, and it's enough. And that is not, that's not business as usual. And that's not cutting down the amount of cigarettes in a package or anything else. This is just plain, be concerned, be caring about people around you.
Thank you for the information. I think it's extremely helpful. Couple questions. Are you folks are you apprised of the transportation from south to north with the drugs? Is it more, car? How are they transporting it? That's my first question. And the second question is for those individuals that come in to Salem Health with potentially an addiction or a crisis, what are the resources if Salem Health isn't able to help? What are the resources that are provided to those individuals? More so focusing on the 18 and older.
Transportation is primarily by passenger vehicle. I was at the southwest border a week ago and received briefings from Customs and Border Protection. And if you ever get a chance to go view that, you will understand the scope of the problem that we're seeing, because it pales in comparison to what is happening across the border. But the briefings that we received were that most of what they're finding are coming across in passenger vehicles, oftentimes with unwitting drivers, meaning that a load is either magnetized to the bottom of a car without somebody knowing that it's occurring. We also were briefed on commercial vehicle operations, and while it's also a big concern, our data and our evaluation of seizures is telling us the same thing. Passenger vehicles mostly is how it's getting here.
I'll just be really quick. When I was on the border, they would come up with all kinds of inventive ways to do the sort of the unknowing, and a lot of times knowing too, from cutting out, the innards of a big grill on a commercial truck, to putting in a false floor, to whatever. Where there's a will, there's a way. There always has been, whether, again, it's on a person or in a passenger vehicle, but it tends to be in a land crossing vehicle. But that does not absolve it from anything from the air or in ships. But for the most part, what we're seeing, like Chris was saying, on the southern border and the northern one as well, we're not, I'm saying that the north doesn't also contribute, so.
And for the treatment options, or with our treatment, so our job in acute care is to first get the person through the initial danger zone, if you will. So whether they're admitted to the ICU for 3 days on a Narcan drip, because that's how long it's going to take the body to metabolize that illegal fentanyl that as I said, is sticky and dirty, to even just getting them through the initial overdose, and then if maybe they're sober enough and for long enough that they can safely be discharged. Salem Health is partnered with the Marion County MAT team, so we use the medication-assisted team, and we can call them 24/7. They show up, and they will take somebody who's interested in getting help and take them on to go get help into the community, which is huge. And then we have care managers in our emergency department and our entire organization that help with anybody who's interested in getting help. They have to be interested in getting help, so you can't force somebody, sadly. I was just talking to somebody just yesterday, sharing what we were going to talk about today, and she has a nephew that is unfortunately addicted to drugs, and she'd reached out to one of our local agencies and just begged them to personally reach out to her nephew on the street and try to get him some help, and they did, and they met him, and they came back and said, he's not ready. So in our culture, you have to be willing to get into treatment. You cannot force people into treatment, as you all know, so that's our reality.
Mayor?
It's on? Okay, thank you. Thank you for leading into my question, because that was exactly what I wanted to ask about. We are a community of people who want to take action, who are passionate for our family members, our community members, and it frustrates all of us. I think I can safely say that what you just described feels like a wall keeping us from doing the right thing for beloved family members and community members. What can we do to break down that barrier that would allow us to work on behalf of people who are making decisions that cost them their lives, cost our families their health, and cost our communities not just millions of dollars, but lives of our young people and people through our community? We want to be able to take action. What can we do to make some progress in this area?
I'll start by saying, go to this website, say, I want to get involved. We'll contact you, and we'll see what ways you can give your time and energy to get involved. That's one thing you can do.
Check that box.
All right.
I can't see over the beautiful bouquet. This problem is so complex. So I would say we've got to start with our children. I've already spoke at South Salem High School. You know, my kids are so sick of hearing of this, although they told me yesterday, "Oh, you're doing a good job, Mom." But, you know, when driving him to school, we were off on Lancaster, and there was a gentleman, it was probably about 32 degrees out, and he was wearing underwear, which was a benefit, and doing a backward crab walk across Lancaster. And they were in elementary school, and I said to them, that's what it looks like when you use drugs. And they'll say to me, and your kids will say to you, "Mom, that's not going to be me. Grandma, it's not going to be me." None of them thought it started there. We have to talk about it. We have to look for the signs. You have to look in their phones. You have to look in their backpacks. Yes, we love our children. Yes, we trust our children. I have 2 honor roll students and a 4.0 unweighted and all this fancy stuff, and I still check her phone all the time because it is everywhere and it is ridiculously cheap. So I would say, please, let's start with our kids. I see our amazing Bridgeway CEO standing there, and he's going to probably have some more information for us. But I would say talk to your children. We have to really speak about this. It can't be something that's just quiet. Look for the signs, as I mentioned, the Benadryl, Imodium, the vaping, the recreational marijuana, and we just have to keep talking about it, getting them help.
Thank you all. I'm Tim Murphy with Bridgeway. Thanks, Nancy. Dr. Olson, nice to see you. This is a huge community problem. We see, so Bridgeway runs the only detox facility in our community, and we see fentanyl every day. We see people using fentanyl knowingly, and we see people using fentanyl unknowingly every day. So what can we do is educate ourselves, and Nancy B. says, educate your children. I have a counselor, Bridgeway has a counselor in every middle school and every high school in the Salem-Keizer School District, and we're talking about this all the time. There's a significant community effort, and there are plenty of resources in the community to answer the question someone brought up earlier. We're a pretty significant provider, Bridgeway is, but there are multiple other providers in the community that are working with people struggling with addiction. The one thing I want to add, we talked about, and some of you used the term getting high, which almost sounds like it's a recreational thing to do. Most everybody we see at the level of care that we provide are treating pain. Not necessarily physical pain from an accident, but the pain that comes with addiction. We didn't go into the neurobiology today. Dr. Olson can do that. She'll take 2 days to do it to you, but she can do it. Addiction causes pain. And when you have something as strong and powerful as fentanyl and xylazine, small amounts of dosing creates significant amount of pain. And the reason you keep using it is to alleviate the pain that comes as that drug wears off. So people are sometimes doing the best they can by using to alleviate the pain they're experiencing. And that pain can be excruciating. So we need to figure out how to support people. And we have the medicine to do it. We have the facilities to do it. We just need the community wherewithal to do that. If you go back 20 years, Dick Withnell is sitting right here. He and I remember quite well No Meth in My Neighborhood, which is how our community responded to the methamphetamine crisis, and it was successful, and it worked, and we shut down all those meth labs that were out in Holmesville and Staten and around the community. We addressed that issue. We need the same sort of community spirit to address fentanyl. And the deaths and overdoses are increasing significantly still. Thanks for your time. Thank you.
Thank you, Tim. And thank you all. I'm going to turn this over to Mike. And I just say, if you want to get involved, go to that website, say, I want to get involved, and we'll respond to you.
Thank you, Jim. First, I'll say apologies for going over a little bit here. Hopefully you'll extend a little bit of grace that we cover such an important topic that's impacting our community. I want to say, wow, amazing presentations. I think it was Dr. Olson shared one important takeaway, which is This is not information or a presentation for us to sit on. It's information for us to share. And the broader we share it, the more impact that we can make. So thank you again. I'm going to go quickly here through some quick thank yous. Thank you to Jackie Roche for singing our national anthem. I want to thank our sponsors at Hagen Hamilton Insurance. They have their team here today. Our sponsors also at Salem Health. Thank you for coming today. Thank you for the presentation. I'd like to get into some of the upcoming events here for you. SalemChamber.org. Go there. They're all on the calendar, right? We've got the Lead Small Business Series Summit coming up in December 5th. We have the Safe Agribusiness Banquet coming up January 17th. I will get into detail here. Next month, we have a very special forum program. Monday, December 9th, 11:30 to 1, we will have, I'm going to be not ageist here, and I'm going to say experienced versus less experienced, a generational discussion, hopes, dreams, and responsibilities, featuring the following individuals. On the veterans team, Gladys Blum, Gene Derfler, and Dick Withnell. And on the emerging leaders team, Portia Schubel, Cynthia Lara, and Boaz Blair. Panel will be facilitated by Ellen Yin from Cubicle to CEO. So thank you to our partners, Sherman, Johnny, and Hoyt, for sponsoring that. I highly encourage you to reserve your tickets now because it's going to fill up quickly. So lastly, as we head into Thanksgiving, the Chamber Board of Directors and staff wish to express our gratitude to every one of you for supporting the strategic work to make Salem a wonderful place to live, work, play, and shop. This holiday season, please seek out local options for your gift-giving generosity. Again, SalemChamber.org has a list of all those places if you can't think of any. So I want to close our meeting today with a special giveaway from the Ross Fresh Markets of our Centerpiece Bouquet, and today's winner is Tricia Morris. Thank you all.
D'aller plus haut, mais je suis